I'm seeing at my practice, we're seeing some patients, really get significant benefit when we get the right drugs for the right patient. So that's why it really matters, and that's why we're talking about it.
So we're going to talk about asthma, which is allergic inflammation of the pipes carrying air to the lung. We're going to talk about COPD, which encompasses two different illnesses, chronic bronchitis, also emphysema. We're going to talk about the role of type 2 inflammation in both conditions. We have to say a disclaimer first. So this session was developed by Vindico Medical Education with an educational grant support from Sanofi and Regeneron Pharmaceuticals. More project information can be viewed in the link in our posts that we posted today. If you guys don't know, right, Dr. Han is a fantastic pulmonary critical care physician, right? She's the Henry Sewell Endowed Professor and Chief of Pulmonary and Critical Care Medicine at the University of Michigan in Ann Arbor. And again, I love that campus. I love the University of Michigan. I love their pulmonary department. I was recently there a couple of months ago with one of her faculty members. It's a fantastic place, a beautiful place, and I love the Midwest. If you guys have questions, you guys can submit your questions to Vindico Medical Education's Instagram or their YouTube pages. You guys are welcome to do that. Obviously, you guys can ask us questions as well, and if we can address them, we'll address them. So, Dr. Han, knowing that you're a pulmonary critical care specialist, knowing that you've done a lot of research in type 2 inflammation and COPD, can you explain to everybody listening what type 2 inflammation is and how it manifests itself in the lungs?
Sure, but before I do that, I think all of our listeners know that you're no slouch yourself. So I think this should just be a conversation between friends.
Yeah.
Um, and Dr. Rutland gives lots of talks on this topic himself. So, but that's something that, yeah, we both deal with. Type 2 inflammation is something that we as physicians are talking a lot about, but I think there's both physicians and a lot of patients who are still not even sure what that even means and is it relevant to them. So type 2 inflammation really is just a type of allergic inflammation that leads to elevated eosinophils, and in the lungs leads to excess mucus production, inflammation, and that manifests as cough and wheezing. And we can see it in asthma, which is kind of where we think about it more traditionally. But we're now also realizing it's present in some other lung conditions like COPD. And it's important, as we're going to talk about more tonight, because there's actually some very specific therapies that target type 2 inflammation that I know we've chatted about this before. I know you're seeing it in your practice. I'm seeing it in my practice. We're seeing some patients, really get significant benefit when we get the right drugs for the right patient. So that's why it really matters, and that's why we're talking about it.
Yeah, and I think, what you guys have to understand is that you have this layer of cells that are constantly exposed to the environment, your epithelial cells, whether they're on your skin, whether they're in your upper airway, your lower airway, your GI tract. And wherever this layer of cells is located, we have to understand that this initiates an inflammatory process because at any given point, at any given time, your epithelial cells, airway epithelial cells that we're specifically referring to, can respond to all sorts of antigens, right? There's so many different things that we inhale on a daily basis. And that's what activates this inflammatory response. And we've come to know as scientists and as educators that there are really three, probably four, three types of inflammation that we can characterize really well. There's type 1, there's type 2, there's type 3. The reason why we spend so much time on type 2 inflammation is because, again, we have specific therapeutics for that inflammation that may be able to calm down some of the consequences that take place as a result of this overstimulation of that airway epithelial cell layer. So when you look at patients with asthma, which again is allergic inflammation of the pipes carrying air to the lung, how common is it to have type 2 inflammation in those patients?
Well, I think for most patients with asthma, there's some element of type 2 inflammation. I think that's sort of how we think about the disease. So I would say it's the majority. Now, yes, there's definitely some that do not seem to respond, but I would say it's more the majority of patients with asthma. It's more in the minority for patients with COPD, but I think it's something we're starting to look into more. One of the other interesting things that I'm finding, I know we're going to talk about it soon, but the more that I'm aware of it, the more I'm looking. And I am finding, and even in patients who have other lung conditions that I wouldn't necessarily have thought, oh, this is a type 2 inflammatory. I'm finding it. And
Yeah.
I'm finding these patients actually benefit. So it's kind of interesting. We traditionally think about it being present in asthma, but it sounds like you're seeing the same thing. We're seeing it in some cases outside of asthma as well.
Yeah, and that leads really to the next question, which is, and the reason why we're looking for it and finding it is because, again, the question is, does it influence which treatments are likely to be
Yeah,
most effective? But of course it does, right? That's why we're looking for it and finding it.
yeah, yeah, absolutely.
So
It's Go
if a
ahead.
patient has inflammation beyond sort of allergic inflammation of the lungs, if they have atopic dermatitis or eczema, if they have chronic sinusitis or nasal polyps or other allergic conditions, do you also look for type 2 inflammation? Are you more likely to find it? What do you think about that?
Yeah, I mean, I think that it all kind of runs together, right? So as specialists, we tend to kind of put one hat on, and like you and I are focusing on the lungs. But type 2 inflammation can pop its head up anywhere and often does manifest in multiple places at the same time. So our asthma patients often have a history of eczema. It's something that, we always ask about, or may have polyps, or may even have esophageal disease. So the good news though is if we target, particularly with systemic therapies, if we target type 2 inflammation, it goes everywhere. And so it will help all aspects of that inflammation, no matter where it's showing up in a particular patient. That's, I think, one of the great things about sort of where we're at with targeted therapies now.
Yeah, and as much as we try to break down type 2 inflammation in regards to where it's located, the more and more I think about it, the more and more I think about it systemically, right? This is systemic inflammation that's applying itself kind of almost in any organ where epithelium kind of exists or is prominent. And so, even more so, my a famous story I always tell is like this 2-year-old at Disneyland in a stroller. I was just sitting next to them in line on Astroblast, waiting to get on Astroblast with my children. And, the kid had a rash all over his body and he was coughing. And I talked to this mom and she was like, oh my God, he's been coughing for so much. So, and it was clearly type 2 inflammation. You could just see it, right? And then the daughter comes over who's like 6 years old, same stuff, eczema, coughing, runny nose. And I remember just kind of pushing this mom over to, a certain clinic. And I said, hey, listen, go to this clinic, make sure that you mention this. You could even say my name. They know who I am. It's fine. Like, it's just so common. And like you said earlier, there's a growing recognition among COPD patients that have type 2 inflammation. The question is, how do patients handle this information? How do we identify type 2 inflammation? And are there certain treatments that we should recommend when these patients specifically demonstrate that they have it?
Yeah, it's interesting. I was just at a patient support group over the weekend and was chatting about this. But as you know, one of the ways, it's not the only way, but one of the ways that we can look for type 2 inflammation is really easy. And most patients probably can pull up their phone, open up their medical record, and find it. And that is eosinophils. It's the cell that we associate most with allergic inflammation, and the number goes up when we have patients that have this as a predominant type of inflammation. Now, what I will say is the number goes up and down. So just because you have one low number may not actually mean much. It also goes down with steroids and other treatments, and then it can go way up when you're having a flare up. And so I, as a physician, try to go back and look at the entire kind of history or spectrum of eosinophil levels. But if those are consistently elevated, or even if you have a few elevated ones, and I'll even go back a couple of years to try to understand the kind of global pattern, that could indicate a patient who has type 2 inflammation. Now, there are a couple of other things that we as respiratory physicians can also do. We can check something called a FeNO, which is a special kind of breathing test, which if elevated also gives me greater confidence that this is this type of inflammation I can target. But like I said, most of the patients most everybody who's probably listening to this right now can pull up their app and actually look to see what their prior eosinophil levels were. And then if you're, curious, you just chat with your doctor, right? Or if you haven't had it done, just chat with your doctor. Say, hey, I heard that there might be some new treatments for with type 2 inflammation. I heard that eosinophils might matter. Can we review these together and tell me whether I'm, this is something that might be right for me?
Yeah, it's interesting when I think of patients, especially patients with asthma, people tend to kind of talk off that they actually have asthma, right? And so they'll say, "Oh, doctor gave me an inhaler with a steroid in it. I only use it sometimes." What I tend to use that eosinophil count for is to convince the patient they have a chronic inflammatory condition that needs to be addressed on a daily basis instead of addressing it sort of on a PRN basis, right, or an as needed basis. And so, again, I had a patient today, a 7-year-old came into me today, was told he had inflammation in his lung, was supposed to be on an inhaler, didn't really use it every day. And I did exactly what you just described. I went into the hospital records and I went back and I looked at his eosinophil count, and it was never less than 510, never less than 510. And so I just basically said, hey, listen, we've got many different types of white blood cells in our body. One of the cells that's associated with allergy is called the eosinophil. It can contribute to airway inflammation. Your eosinophil count is high, right? And any number above, like, I don't know, it kind of depends, like 150, 200, whatever if you think it's contributing to their airway disease, it's probably contributing to their airway disease. So that number's high. And I just kind of said, listen, you're going to have to use this inhaler every single day. And then when you use the inhaler every single day, if these patients continue to have symptoms, right, they're continuing to wheeze, cough, they're continuing to get admitted into the hospitals or ERs with shortness of breath, those are red flags that can signal uncontrolled inflammation. Is there anything else besides those things that I just mentioned that is a red flag for you and tells you to reevaluate a treatment plan?
Well, I think whenever the patient's symptoms are uncontrolled, right? So if they're telling you that they're really short of breath, if they're using their rescue inhaler quite a bit, if they're needing multiple courses of steroids, those are all indications that we could be doing better. Now, it doesn't mean that in every case we're going to be able to get symptoms to zero and no flare-ups whatsoever. But I think for patients with type 2 inflammation, some of the newer medications out there are really good.
Mm-hmm.
I don't know what you're seeing in your practice, but it's unlike what I saw 20 years ago in my practice. I think I'm
Yeah.
older than you are, but yeah, it's definitely they've been game changers. Absolutely.
Yeah, it's interesting. Everybody thinks I'm like this young guy. I'm 44 years old, and so I kind of grew up at the time when medicine was transitioning from this old school way to this kind of new school way that's probably a little bit softer. But, the benefit of that for me is being able to actually see the change that has taken place, especially in respiratory medicine from, early 2000s when I was in medical school to now 2025. And it is very fascinating, fully understanding that this communication between white blood cells and epithelium is constantly taking place. And you can actually understand specific mediators that are allowing this communication to take place more than it should, allowing students to talk in class, and that class gets really, really loud, right? Like in the airway, when it gets really, really loud and these patients are wheezing and coughing. I think fully understanding that has allowed us to see why biologics not only work in respiratory conditions, but across different epithelial inflammatory conditions. I mean, do you feel that way too?
Yeah, no, I think it's really exciting. For the patients with type 2 inflammation, we've seen, I've had patients who were on 30 milligrams of prednisone and couldn't get off. And we've gotten them off of steroids. For some patients, it is absolutely life changing. Not for everyone, but for some patients, it's absolutely game changer. Having said that, unfortunately, not everybody has type 2 inflammation. And so I just want to, for anybody out there listening where this doesn't apply, the good news is there's a lot of research going into other inflammatory pathways. And I am very hopeful that in the next few years, we'll have targets for type 1 and type 3 inflammation that Jamie talked about. So I think, I'm hoping that this is just the tip of the iceberg, right? That we'll have more and more targeted treatments for patients moving forward.
Yeah, and as we have more and more targeted treatments, and as we continue to understand the inflammatory process that takes place within the body, we have to do a better job of teaching our patients and their loved ones about this process, okay? Because a lot of times, people will come in and they have been to multiple urgent cares, multiple ERs, multiple physicians, and they still don't quite understand what asthma is or what COPD is. And a lot of times, you know, patients will kind of almost lump the conditions together, which I'm kind of okay with. And that's where it comes to COPD asthma overlap. When you think about these patients, are there special considerations you make for them, or do you sort of try to separate these patients? Like, what's your plan when you see these types of patients?
Challenging. I just had a colleague email me today and said, this, whatever this insurance company really needs to know, is this asthma or is this COPD? And he kind of, like ran it down for me. And I'm like, it's both.
Right.
So, you're right. And they're right. It's both.
Yeah.
um, this is one of the challenging things. We tend to think about asthma as more allergically driven inflammation. We tend to think about COPD as more related to chronic noxious exposures.
Yeah.
So for patients who have both asthma and COPD, I think that I tend to think they tend to be more type 2 inflammation heavy. They tend to have a lot of frequent events. They tend to be very short breath, very wheezy, be more asthma like. And so I tend to treat them more like asthma. And so that means inhaled steroids, and they probably, in many cases, they are candidates for some of the medications we were just talking about with respect to targeting type 2 inflammation. I don't know. Is that what you're
Yeah.
seeing in practice?
I, people get mad at me, but whenever I see an asthma COPD overlap, I mean, I always say disease doesn't read books. And so for me, when I see it overlap, I get excited because what it does for my COPD patients that have COPD asthma overlap or what have you, like it actually opens up the doors for more therapies for them. So I really, really
Yeah,
like it
yeah,
when
yeah,
they have
yeah.
an
Yeah.
overlap syndrome. And I 100% agree, those individuals that have a COPD overlap syndrome probably are more likely to have strong type 2 inflammation contributing to their airway disease. And again, it gives us options for therapy for these patients, which I think is pivotal. I think it's vital. I think it's great for their disease state because it allows them to hopefully feel better sooner. What advice would you give to patients or caregivers who feel like their breathing issues aren't being taken seriously and they've been stuck on the same meds or they've been stuck in the same kind of clinical scenario for years?
Yeah, this is really hard because this
Mm-hmm.
is where you've got to start having conversations with your physician. And I'm sure I've seen it. I know you've seen it. Sometimes this is how you get new patients because they've had these conversations with their doctors and they said, just saw a patient like this last week and she said, I love my doctor. I've been going to this doctor for 20 years. I will go back to them, but I just told him I need a fresh set of eyes.
Yeah.
It actually turns out this particular patient, you'll appreciate these numbers. They had an FeNO of 62.
Wow.
And I very much a candidate for
Yeah.
some of the medications that we're talking about. So this is why you and I are having this discussion tonight.
Yeah.
So I think, do we have targeted treatments, new treatments for everybody? No, we don't. And there will be still some patients that we're still waiting. Right, we've got a lot of clinical trials going on, but at least for COPD, we've had 3 new drugs approved in the last year. 3, which I know maybe doesn't sound like a lot, but
It's a lot.
for for us, it's a lot because we're not like cardiology or some of the other diseases that get like 5 new drugs a year. That's not us, right? We've had the same drugs for about the last 20 years. So just the fact that we've had 3 new approvals in the last year, it is not a bad time to go back in and chat with your doctor and said, hey, I saw this Instagram live the other day and I heard that there's treatments that were approved.
Right.
Am I a candidate? And if the answer is no, it's no. And
Right.
like I said, we've got lots of, but it doesn't hurt to ask, is there anything new? Because we actually do have some new medications that were approved.
Yeah, and I think it goes to show when you think about 3 drugs that were approved within the last year for COPD, and then 3 drugs all having a different mechanism of action, is very, very important. And what it tells me is to the trainees, to the fellows, like you can't be a pulmonologist like you're attending that has more life experience because it's changing rapidly or we're learning new things rapidly and you have to keep up with that pace, right? Like you said, pulmonology was kind of stale for 20 years, 25 years. We didn't have anything new. And now we're getting new things all the time. And so you have to stay up to date. So when you're teaching your fellows and when you're teaching, the learners, they are now beginning to understand that immunology is important to understand in our field of medicine. It's very important to understand because we are manipulating it on a daily basis, right? We're not dropping bombs anymore with corticosteroids. We're being specific. We're targeting specific things with drones, as I like to say. And so I think that's very, very important for the new learners to understand. Um, so it's a
Well,
very exciting.
I'm
It's very exciting.
curious what you're seeing, Jamie, because what I will say is that, when I go and talk to my colleagues or I see patients come in from the outside that are coming in for second opinions, I don't think we've done a good job getting the word out.
No,
Like
I
I
don't. Yeah, that's one of the reasons why I do what I do. It's one of the reasons why I started the podcast. It's one of the reasons why I have YouTube. It's one of the reasons why, even though I am not excited about traveling all over the world to speak, I mean, it's cool for a while, but you know how tiring it is. You got your kids growing up. You don't want to miss games. You don't want to miss performances. I do it because I know that we have to do a better job of communicating that message, right? And I think the patients that come in, I mean, God, I saw 15 patients or 16 patients today, and it's so funny. Like half of them are new patients and they're 75 years old. They've had these conditions for years and they don't understand them. And it's like, for me, it's just kind of like, whoa. And when you go out and you do this, like I was in Kansas City delivering a lecture, and I trained in Kansas City at KU Med, literally 2 miles away from the clinic I went to. And I don't want to say it's a lack of knowledge, but the lack of new knowledge that they weren't receiving was astounding to me. And so I think we have to have that energy to be able to go out there and try to narrow that gap. It's hard these days. I get it, but we got to do a better job of that. I mean, that's why we go to Canada in April when it's supposed to be spring, but it's a blizzard. Like, but like that's why we do things like that, is to make certain that, you know, everybody receives this information in the way that they can understand and then apply it to their patients that they see on a daily basis. So,
yeah.
um, I think we're out of time. Again, you guys, we're going to place this on our feeds. It's going to be posted on Vindico's Medical Education's Instagram and on their YouTube pages. Um, I just want to thank at Vindico Live. Again, I want to remind everybody this was supported by an educational grant from Sanofi and Regeneron Pharmaceuticals. Remember, these pharmaceutical companies also support us being educated and being and understanding these disease processes for the people that we treat every single day. So, thank you guys for joining, Dr. Han. Thanks
Thanks
for
for everybody's patience with
yeah,
me and Instagram. I appreciate it.
me too. And thanks for spending time on Wednesday night. And we will see you all soon. And Dr. Han, I'm sure I'll see you soon.
Yeah. All right. Bye, everyone. Bye,
Take
Jamie.
care. Bye bye.